In this episode, I sit down with Larry Bilbrey, one of the most respected voices at the intersection of oncology, data, and digital transformation. Larry is a director of data insights and innovations at Tennessee Oncology and the senior director of digital innovation at OneOncology. With nearly 2 decades of experience in oncology operations, data systems, and AI-driven transformation, plus leadership roles at ASCO and Myriad Genetics and bylines in some of the most respected oncology journals, Larry brings a rare depth of perspective in how innovation really happens in the field. We talk about what it takes to actually implement AI in high-stakes, high-volume care settings, what ROI actually means when you're serving physician-owned practices, and what ambient AI is unlocking in unstructured data that's been hidden for decades. If you care about building for healthcare, scaling thoughtfully, or creating products that actually serve patients and providers, this one's for you. Hey, Larry, thanks for joining us.
Yeah, of course. Happy to be here.
So let's get right into it. So I think where I want to start is, I think you've got a really unique role. Like you lead digital innovation at both the Tennessee Oncology level and at the OneOncology level. And I think from that position, you get to see both like the day-to-day inside like large practice and also the bigger picture challenges across kind of a national network. And so I wanted to just start by asking you, how do you think that like that dual lens shapes the way, you approach innovation?
Yeah. With Tennessee Oncology, so I've been there almost 20 years. So I've been doing this for a long time. And when I first started with Tennessee Oncology, I think I was like employee, if you don't include the physicians, I was like employee 110. And now I think are close to 1,800 employees or something like that. So I've seen the growth of Tennessee Oncology from a smaller private practice up to where we are now, where I think we're the third largest private oncology practice in the nation, 300 providers. And the challenges that a community practice, even one the size of Tennessee Oncology, faces are pretty unique. They're definitely different than like what academic centers face. I think there's a lot of different funding sources and things like that academic centers have between endowments and, their tuitions, et cetera, et cetera. And, we're really reliant on our billing, right? That's basically what we have at private practice level is what can we bill for, and then how do we take that money and make it work across all of the different needs that we have for the practice. And so when you go to the network level at OneOncology, you sort of exacerbate some of those challenges, and so you need a OneOncology to be able to help cover different solutions and brainstorming and things like that. But then there's also, we do have a Tennessee Oncology who is the largest practice, I think, from a physician standpoint at OneOncology, or at least it's one of the largest, down to, I think we have some practices who only have like 5 doctors, right? And so even within our own network, there are very different levels of challenges that we have to try to address. And I think as we're getting into this world of AI and, digital transformation and things like that, that's what I am realizing is, I see, to your point, I see the day-to-day at Tennessee Oncology. I used to be operations there for years and years. I was a regional manager with them and ran several clinics and worked with the physicians side by side. So very, very familiar with the challenges that they face from a day-to-day standpoint operationally. I work in the corporate office now, or the home office for Tennessee Oncology now. So I have that view of what we face from a business enterprise standpoint as well. And when you take that to OneOncology, it is really interesting. So I'll give an example. Like one of the big projects that we're working on right now is trying to see if there's a way that we could use AI agents to help us with rescheduling, right? And then when you look at a Tennessee Oncology, our rescheduling or our scheduling call volume just in general is like 50,000 calls a month. Just at Tennessee Oncology, right? But, at a practice, another practice that's only 5 doctors, it might be, 500 a month or something like that, right? And so the difference in scale is it's important because the solution that works for a Tennessee Oncology may or may not work for that little 5-doctor practice. But then there are some things that are global and maybe we are able, and this is one of the things I try to think about from the OneOncology lens is there a way that I can bring a solution in and scale it, build it in a way and scale it that it does work for a Tennessee Oncology and it does work for a 5-doctor practice, right? So it's difficult, it's doable. Sometimes the contracting is a little tough too, right? Because like, how do you scale that pricing across those different sizes? And when we're talking to vendors, sometimes they think in terms of those smaller practices, and they're like, oh, this only costs you $1,000 per physician per month, and if you only have 5 doctors, it's $5,000 a month. It's not bad, but if you have 300, that's a significant chunk of money, right? And but fortunately, usually with volume, because discounts and things like that. So that's one of the big things that we have to do. I think there's another challenge that I've noticed is sort of philosophy, right? Like, if you have a practice that's very progressive and wants to find these solutions and implement them quickly, try to go through different iterations, sort of the agile fail forward kind of framework, let's put something in quick and then iterate on it, try to make it better. And then you have other, practices, their philosophy may be that, we're going to kind of wait and see how this whole AI landscape plays out. And so they may not be willing, when I come up with an idea or someone at OneOncology comes up with an idea of a solution and we go to the practices and say, hey, here's what we're thinking, there's a potential you're going to have practices that are just like, yeah, I don't see that. We're not there yet. And so, so what do you do then? Like, do we just go ahead and run it for half the practices and hope that the other half of the practices jump on board? So that's a challenge that we have to think about as well. That's probably the biggest sort of thing that I think about when I'm looking at these different solutions.
And is that typically how you're seeing AI being adopted today, where because at the network level, you might have so many different perspectives on, hey, like we should be the first mover versus, hey, we should be, a fast follower, or, hey, we want to wait, really long until it's fully vetted and then adopt it. Like, how are you seeing that actually play out? Is it like, hey, like as a network, we're able to just all unite and say, hey, we want to adopt one philosophy? Or is it usually happening kind of what you described, where you just have the really innovative kind of groups kind of lead the charge, and the rest of the network benefits and adopts at their own timeline?
Yeah. So it really depends on the solution itself, right? So I think that the AI landscape is so broad right now. So I'll use RCM as an example. I think, there are some very real tangible ROIs on the AI side for RCM, right? And so when you go to a network like a OneOncology or US Oncology or even the academic centers, I think it's easy to, if your solution is, hey, we have the ability to help you with your E&M coding, right? And we can help you more accurately code and I guess there could be a downside to this too if you're upcoding too much and it brings you down, but you'd be more in compliance, right? So from a liability and legal standpoint, you're more covered. But I think, in my experience, and this is just experiential, I have no data to back this up currently, but I think physicians tend to undercode because there are so many rules and expectations around, from the insurance companies, from Medicare, around the E&M codes, that they want to make sure that they're not doing anything that could be considered wrong or get them audited or anything like that, right? And so if you are able to bring in an AI solution that says, 50% of the time, when you are coding a level 3, you might be able to actually, because of the complexity that you've documented, the time that you spent with the patient. Again, I think the key word to keep here is appropriateness, right? As long as it's appropriate, that, you could have coded this at a level 4, then there's actual tangible ROI between those differences, right? You take that volume, you multiply it by the difference in the E&M, and you have an actual number at the end that says, oh, well, this solution can net me, I'm just going to make it an arbitrary number. It can net me $1 million extra in revenue a year, right? And then you sort of weigh that against the cost of the solution, the support, and all that stuff. And then it makes that sort of easy to make a decision, or easier, I should say. There's still sort of the legal and compliance stuff that I think everyone's trying to wrap their heads around. But from a pure ROI standpoint, that's black and white. But I think there are some other solutions that are more qualitative, right? Like they're quality of life solutions, and there's not firm ROI behind them. And so those are a much harder sell to any leadership team, finance team. So really that's how I'm approaching it. Is when I'm speaking to a vendor, I mean, the first conversation that I have with them is, how are you determining your ROI? And, one of the things that I've explained to several vendors is, you kind of have to work with us, because in all software solutions before AI, or at least for the last 10 years or so, it's really easy for us to take what we have now and compare to what's on the market. So I'll just use an EMR as an example. So you have an EMR, how that EMR functions, and you go to the point where you're in the market for a new EMR potentially. You're able to look at these other EMRs and you can do apples to apples comparisons on certain things and functionalities within the system. You can look at the cost structure, you can look at the contracting, but you have that experience that's already in your back pocket from years of already working with this one EMR or two EMRs, however many you've had before. Well, with AI, it's so new, we don't have any previous experience, right? And so when a vendor is coming to me and saying, oh, I have this ROI that I can show you, you sort of almost have to take their word for it, right? Because you don't have any experience, so, going back to the RCM standpoint, like, we can upcode you 50%, it's saying, but like, we haven't seen that before. So we just got to kind of trust that that's the results we're going to see over the next year. So, I think with a lot of the things that we're doing, pilots are the most important thing right now with these AI vendors. So some of it is, training the models, seeing what they're capable of. But I think a lot of it is for us as well, so that we understand what the product is doing. We feel comfortable with the results that it's producing, and sort of what the trajectory is of, where it's going to be in the next year, 2 years, things like that. So, yeah, it depends on. So I know it was a really long-winded answer.
No, that was great.
Your question, but yeah, it just really depends on the solution, how we approach it, and we're definitely much more guarded depending on, like, can we put that dollar value to it? And if we can't, how are we going to show ROI? And I'll be honest with you, some of my job is finding that ROI, going to the leadership, the executive teams at both OneOncology and Tennessee Oncology, and trying to make the sell, right? Like, to say, hey, I think that there's a lot of value here. We're going to be able to do X, Y, and Z down the road. So I sort of need you to trust me that I know what I'm talking about too when I evaluate these solutions. So
it sounds like having that hard attributable ROI is kind of the thing that you can do to really accelerate the adoption of AI, or going through that kind of procurement process as a vendor. I'm curious, like, I think one of the things that I found interesting in especially the community oncology space was how many of those practices are physician owned, and how a lot of those, decisions are ultimately done, in the benefit of the physicians that own the practice versus, some of the other health system partners that we work with, they employ their physicians.
Sure.
And so I'm curious, like, when you're thinking about things to adopt and what, you're having the practice focus on, how do you think that kind of dynamic changes, like, the solutions that you guys are looking for versus the solutions kind of other people are looking for?
Yeah, it definitely does. I mean, I will admit some ignorance on, like, how evaluations happen at, like, academic medical centers and large hospital networks, just because I've never been a part of those. So I don't want to make any assumptions about how they do things. But I think they're, HCA, who's one of our partners here in our backyard, they are a huge corporation, huge capital, publicly traded, so I think when you're going to make budgets for certain things, if you're making an AI budget, right, like, you have a lot more capital to play with, right, than even a practice as large as Tennessee Oncology. Again, we sort of rely on the actual things that we're doing to take care of patients to drive our revenue. And so, we don't have stock prices that can go up and fluctuate to bring in additional revenue and, do any sort of sales or anything like that helps bring in additional revenue. So I think everything we have to do, we have to weigh with what is it costing us today to do it with, and I'm talking about AI solutions specifically right now. What is it costing us today with people to do it versus if an AI solution is able to sort of supplement or replace a piece of that, how much is that going to cost us, over, the X period of time to be able to do it? And is there a savings? Ron, my CFO at Tennessee Oncology, he always tells me, and I think it's a great, just sort of simple way to look at it. So, would you spend $1 to make $2, or would you spend $1 to save $2? And generally the answer is yes, right? And so, if you're able to come to the table with a clear way to make $2 or save $2 by spending $1, it makes those conversations, those decisions a lot easier. But I think what we're seeing is because we don't have that clear ROI, when I go to Ron and Dr. Dixon and the executives at Tennessee Oncology, I mean, we have to be very protective of what capital that we do have. And, if a vendor comes to us with a $600,000 a year solution with no clear ROI on the back end, that's a really tough sale, right? Like, because that's $600,000 that will just be gone, and we have no way of getting that back. We have to see more patients in order to get that back. And I think everyone knows that there's a shortage of oncologists. We see as many patients as we can. Of course, TO is growing, and we'll see every patient that comes in our door. But like making up $600,000 that's a lot of patients, right? So yeah. I mean, we definitely, I think, have to approach it much differently than the academic medical centers and the health systems, because we just don't have the capital to play with like they do.
Yeah. And it's really interesting to see that dynamic play out because, what I would say is without that budget or that flexibility, it makes it much harder to innovate. But at the same time, like, we've been working with you guys for quite some time now, and it's pretty clear that that's not stopping you.
No, and I think that's a testament to leadership, right? I mean, I think if your executive leadership, your board, even the partnership, right? Because Tennessee Oncology is a partnership. If they're agreed to be innovative, then they'll usually support that innovation. This even goes back to Dr. Patton, who was our CEO at Tennessee Oncology, who's now the CEO at OneOncology. And he was always about innovation and growing Tennessee Oncology, making the experience better for the patients, making the experience better for the physicians and the staff. And he took that philosophy to OneOncology. And so even though we may not have the capital budgets of a large HCA, we still have the innovative mindset, and we're going to figure out a way to make that work, even without $1 billion behind it, just to do R&D. So
yeah, I think it's a huge strategic commitment, right? Because I think a lot of times when you're so ROI driven, sometimes you miss the forest through the trees, right? Like I've had my fair share of people asking me, how what is Deep Scribe's ROI? Like, how am I making more revenue by saving doctors time if they don't see another patient? And, I've had challenges where a lot of times they would institute these programs where they would subsidize the cost for our product because if they were to see additional patients. And I'm like, guys, like this is the antithesis of what we're trying to accomplish. Like we're trying to restore the joy of care to medicine. And, if you just take the time savings that we make and force them to see more patients with that, it just becomes a very, very, you take one step forward, two step back kind of dynamic. So I think what we're seeing now is that like, people are really viewing the move to AI being kind of a more AI native organization as being a truly like a strategic decision, right? Like, as you move forward, you need to actually be able to adopt these tools in order to actually compete, right? So it's not a matter of innovating, but it's a matter of, really making sure that you remain competitive and, you can continue to deliver care for patients the best you can.
And I agree with a lot of what you just said. I think, and I have not witnessed this. I think being physician owned, we are definitely very physician centric and very physician friendly, right? These oncologists are already seeing 25, 30, 40 patients a day, right?
Yeah.
And like asking them to see more patients is, I don't think that's what everyone's looking to do. And so I agree with you that that's probably not the right approach when it comes to like the deep scribe type things. I think, quality, there is an ROI in quality, but it just depends on who the audience is, right? And so with a scribe, going to a physician, I'll just use our personal experience at Tennessee Oncology with one of our physicians, Dr. Todd Bauer. He I don't think he would mind me saying this. I think he would agree. He was sort of against AI and the AI scribe thing in the beginning. So when I first brought this to leadership as an idea, when you and I first started talking, last year, Matt, and I took the idea to our PI committee, which is a physician leadership committee, there was a lot of people who were skeptical, I think, about AI, and he was one of them. And so I asked the committee for them all to be pilots as we were sort of looking to do these scribe pilots. And most of them agreed. There was a couple that said they didn't want anything to do with it. And Dr. Bauer was one of them that said, I don't want anything to do with this. And then not long before the pilot, I think he'd, been thinking about it, probably heard chatter over the months when we were getting contracts done and stuff like that. He reached out to me, he said, hey, I probably need to get on board. This is probably the future. Is it too late for me to get on this pilot? And so I was like, of course not. I'll get you on the pilot. And so he was one of the first physicians that went on when we rolled out Deep Scribe. Yeah. And I think even in the beginning of the day, he was sort of visibly and openly upset about how it was going. Like he was not happy at all. It was slowing him down. It wasn't doing what he thought it was going to do. And he, like, I think from the very beginning, he was like, this is going to work. But by the end of that first day, that same day, he was like, wow, this is pretty cool. Like, and then so much so, and this is sort of paraphrasing him, but by the end of the week, I think he had communicated out to several of us that this was one of the first times in a while that he didn't have to take notes home over the weekend to finish his notes.
Yeah.
And so that quality of life change for him just in 1 week was massive. Right. And so there's ROI there, right? And if you go to a physician and say, hey, it's going to cost you X dollars to get, 6 hours of your week back and your whole weekend back, they'd probably be like, well, who do I send the check to? Yeah. Right. Yeah. So, I agree with you. I think ROI is a tough pitch. And you have to make sure that you're focusing on the correct ROI for the solution, to really make sure that you're showing the value of the product.
Yeah, and I think it's a really good lesson on how you implement AI, right? Like I think a lot of people view AI and AI tools as something that's just magically going to solve their problems, but in reality, they're tools, and like any tool, you really have to learn how to use them, and especially when you're implementing a technology that is often met with so much skepticism, and a lot of people are unwilling to change. Sometimes the people that are the most vocal about being unwilling to change, those end up becoming the strongest champions, right? Mm-hmm. And I think that has a ripple effect when other people see that, right? And they're saying, even if they were on the fence, if they're like, wow, if they can get him or her to use this, then wow, there's really something there. And we found that as like a really important strategic tactic for us to try to establish trust with our customers early on, and it's really worked. And so it's one of those things where you can build the best technology, but the best technology doesn't always win. And you need to really figure out how do you implement the technology in a way that's thoughtful and that really brings people along. And especially in healthcare, I think that's one of the hardest places to do that.
Agree. Totally agree. And I think, talking about your implementation strategy, I think you're spot on with how, I think this goes back to sort of what you were even talking about earlier with, how do we look at this from like a OneOncology network perspective, or even down to the individual practice. I think you do have to be really strategic about who you pick to be some of your early adopters in your pilot practices or physicians. And you don't want to only pick like the cohort of physicians that are tech savvy and like young and gonna adopt technology because they've been on an iPhone their whole adult life. You do want to be thoughtful and say, hey, where is that 30 plus year physician that's in their 50s or 60s that might not be as tech savvy? Can we make this work for that physician? I think to your point, if you can make it work for a physician like that, where they're able to adopt it, embrace it, it's easy, it makes sense to them, then I think that's a huge win right there, right? And obviously those physicians will phase out, but it's AI now. We don't know what it's going to be tomorrow, right? These physicians who are 30 years old coming out of fellowship now, they're going to be those grizzled veterans in a few years. And so, are they going to be able to embrace the new technology? So I agree with you totally. You have to be really smart and strategic and thoughtful about how you're doing these opening sort of cohorts and demos and proof of concepts and things.
Yeah. So shifting gears a little bit, Larry, I wanted to, ask you, I think we've spent a lot of time, off the record, just talking about kind of the future of cancer care and, especially about like what ambient really evolves into. And so I'm curious to get your take on, you start with documentation, but, you have this kind of strategic asset that you're developing over time. And, I'm curious where you see that going, right? Like, and, I know you and I have thrown around a few ideas of things that we wanted to work on together. But yeah, I'm just wondering if you can kind of talk a little bit about, where you see kind of ambient going from here.
Yeah. So I think I'll have to take a step back to get to that. So I think what's really important for everyone, and most people I think probably know this, but maybe haven't ever had it articulated or thought about it in a really specific way, is that, the biggest problem we have when it comes to AI or any of these technical solutions is data, right? The data quality, the amount of sources, the formats, I mean, the endless counts of how data is formatted is in healthcare is just, it's insane. Right. And I think even going back to George Bush, when the original sort of version of the Cures Act was put in place, and I can't remember what they called it back then, but, when he first sort of made what do they call it, meaningful use, I think is what they call it. It's MIPS now, meaningful use, a thing back then. The idea was sort of like, how do we standardize this data across the healthcare network so that we can move forward? And I think, companies like you and many companies like yours, and then even at the practice side like us, we've noticed there's not been a ton of change in that data quality over the last 10, 20 years, right? And so what I realized many years ago, being on the data side at Tennessee Oncology, was the unstructured data, and specifically the physician's note, is like the holy grail of data, right? Because in the way that a lot of these EMR systems are developed, there's not discrete data coming into the system in certain ways. Now, if you work at an academic medical center and everything that you do is under one roof, and like the pathology labs just down the hall and the CT scanners across the hall, and all this stuff is happening all within the same EMR, that changes the dynamic a little bit. But in sort of the real world, those of us who take care of the patients, the majority of the patients, we don't have the scanners on the same EMR. The pathologists are their own group working on their own EMR somewhere, probably at a hospital system somewhere. And we know that these EMRs don't talk to each other. So when we send out for a pathology, it's being done at a hospital somewhere, and then we're getting a fax back. That's scanned fax too, right? Not even like, like a HL7 base 64, but an actual scanned document that's an image, that there's no easy way to get that data, especially, if you go 10 years back, there was no way to get data out of it. OCR was so awful back then. So anyway, so the physicians, they're not taking those documents and then doing data entry and putting in those discrete fields, having the document up and say, oh, okay, so here's the T, here's the N, here's the M. They're not doing all of that. What they're doing is, going back to when they were dictating, of course, typing their notes, and now we're on to the AI scribes. They're putting in their note, T and M, blah, blah, blah. And that's where it was. And that was appropriate. It was documented, it was in the chart. It just wasn't in a discrete field that made it easy for people like me and you to be able to do anything with it,
Yeah.
right? And so, yeah, so that's what I have been chasing. I think that's what we've all been chasing for however many years now. And I think that's where AI and the scribes are specifically going to make a huge shift in the data world of healthcare, right? Is that we now can have access to this holy grail of data that we've never had access before unless we paid a whole army of abstractors to go in there
Yeah.
and pull it out, right? And so I think with AI scribes specifically, you guys are writing the notes. You're recording the visit with the doctor and the physician in the exam room. You're basically becoming the source of truth at that point, right? Because if the physicians, the EMRs haven't changed, and the workflow of us sending out pathology hasn't changed. We're still sending it to that path group at the hospital. They're still faxing that, ugly scan document back to us. We're working on that, but we're not quite there yet. And so the doctor still, even whether they're doing it ambiently in the room or they're adding it to the note when they get back to the EMR, it's still living in that physician note, right? And so I think having a company like yours that is a technology company that is taking that data and turning it into discrete data that we can then action on.
Mm-hmm.
I mean, it's a game changer, right? It's, to use the staging information as an example. I mean, we need that staging information for so many things. I mean, we need it for regulatory and government reporting like EOM. We need it to make treatment decisions and Flatiron Assist, right?
Mm-hmm.
For our EMR. So yeah, like having that data in discrete data fields, being able to action it, move it to where we need it to move, and then I think build upon it. Like, everyone's talking about clinical decision support. I personally don't think we're there yet. I think we've got
Mm-hmm.
years to go before true clinical decision support happens. But I also think one of the main reasons why we're years from is because of the data, because we don't have, if I were to put a AI on just a random practices data set and say, okay, hey, go and tell me like what treatment recommendation would you make for, this 100 patients, it would be I don't think it'd be very accurate because it didn't have the data to make the decision. Like the AI might be smart enough to make the decisions, but it doesn't have the data to make the decisions, right? And so, so I think that's where these AI scribes are really going to help open the door to getting this data that's lived in these physician notes for so long into places where we can actually start innovating, like true innovation towards clinical decision support, research, matching and things like that. So
Yeah. I mean, I think that was one of the most eye-opening things for me when we were starting our company was, we would listen to these conversations that were filled with so much color and so much life and so much detail. And then we would read these notes that these doctors are writing, and a lot of that, detail was lost.
sure.
Right. And, that detail, that lost information can contain very important, context for what is the best kind of treatment for that patient. And, I think when we were building Describe, we were really intentional about, building the product in a way that is not just automating documentation, but is really laying that foundation for kind of the future of applications that you can build that sit upon these insights that you can gather from these conversations, right? Like, what we thought was, so much of healthcare's potential was being limited by what physicians can remember and what they think is important to write down. And I think with ambient tools, you get 1 degree closer to the truth of what actually happened. And that really like allows us to kind of shift, I guess, today the system of record, if you will, is based off of what someone can remember and what someone can think is important and input it into the EHR. But tomorrow, I think the system of record is going to be, a patient journey that's constructed with all of these, micro interactions that we have with our patients, whether it be the conversation at the point of care, whether it's a call that they make into the practice, all these little things we can really pick up on and change the way we deliver care. I'm curious, like, a lot of this discrete data, you mentioned things like Flatiron Assist, like clinical decision support, Like, what are you most excited about in terms of, hey, like, we know that this is possible if we were to just get this data. Like, what is one of the things that you're most excited about?
Yeah, I mean, the thing I realized back in probably like 2020, and full transparency, I'm not a data person, by training. I was a business person, I was in operations, and sort of fell into the data thing. But what I was realizing was, healthcare has a ton of data, and we've always had a ton of data. But again, it lives
Yeah.
in these unstructured fields, you know, physician notes, scan documents, but there's no shortage of data. And what I sort of realized was that the biggest challenge that physicians, clinicians have is that there is so much data. If you have a patient in front of you for 15 minutes, it's, I think, physically impossible. I don't think the smartest, quickest person on the earth could go through all the data that we have on a patient to do anything meaningful with that, right? And so I realized really early that my sort of guiding light in data, and now going to the AI side of things, is that how do I get the relevant data in front of the physician at the point of care?
Mm.
Right. And so they're sitting with that patient for that 15-minute visit. How do we make sure that those recent biomarker tests, those recent lab results, those recent scan results, all the things that are relevant to that visit that's going on right then in that time, how do I make sure that the physician can find it easily, quickly, it's in front of them? Right. So I think that's probably what I'm the most excited about with all of this is, I do think AI is going to make some really big impacts in the clinical decision support space over a course of 5 to 10 years. But I think before we even think about getting to that, what's the old adage? Think global, buy local, or whatever. Like take care of your own house first, right? And so I think like how do we make sure that the physicians who are seeing the patients day to day have all the tools they need to make those, because they're the ones still making the decisions. Who knows if they'll be making them in the future? I think they always will be, but I think there's some different opinions out there. But for now, they're the ones making the decisions. So since they're the ones making the decisions, let's get them everything that we can so they can make those decisions as accurately as possible. And so that's really where I think AI is going to make the biggest splash, at least maybe in my world, in the community world. But I think in all of oncology, if we can get all of this data in a very organized, discrete, good UI, works well with the EMR, and they've got the patient in front of them. Here it is. Here's all the relevant information that they need. That to me, that's what I'm most excited about. That's what I'm working towards every day is trying to make that a reality.
Yeah. Yeah. I mean, one stat that my chief medical officer told me, and I didn't believe in it, I had to look it up, was that the amount of medical information doubles every 73 days. And,
wow, I've never heard that.
Yeah. And I looked it up because I didn't believe him. And there's actually like a pretty, comprehensive study that was done on it. And yeah, healthcare information doubles every 73 days. And think about that as a physician, right? And, being able to stay on top of all that to make sure you're practicing at the top of your license is so hard. But even in oncology, I think it becomes harder because when I talk to these oncologists, I think the most challenging thing is like navigating the complexity of all the different new therapeutics out there, right? There's so much innovation happening in terms of how do we actually treat cancer patients, that staying on top of all that is really becoming the hardest part of being an oncologist. And so I think that the pain is felt, more sharply in kind of the space that you and I both work in. So.
No, I totally agree with that. I think that especially in the community, in the rural settings, where you have a physician that has to treat, specialties are going to differ. And, in oncology, we're obviously dealing with very sick patients. But when you're talking about these rural clinics, these rural oncologists that have to treat lung cancer, breast cancer, colon cancer, and they don't really have the opportunity to specialize like an academic person because, they have 50 different physicians and they can each specialize in all these very specific branches of these cancers, right? And, when you got this rural oncologist out in the middle of nowhere that's, seeing 1,000 patients, they got to treat everything, right? And so you're exactly right. Like how does that person stay an expert on 70 different diseases and be able to make the correct treatment decisions? And yeah, I think we're finally getting to, and don't get me wrong, these physicians are brilliant and
Yeah, they are.
they have great work ethics, and they know the places to go, the up to dates, and the things like that to get the most current guidelines, and they are great at talking to their peers. So I make no mistake, I'm not knocking that rural physician. We need that rural physician. He's the hero. She
Exactly.
is the hero of all of oncology. So I don't want this to sound like I'm bashing rural medicine at all. I'm not.
No.
They are the most important, if anything, and we need to support them. Right. We need to make sure that they can continue to do that, what they're doing, and they feel good about it. They don't feel like they're going to get any sort of legal action taken against them because, they don't have the expertise that, some academic physician has. And so, yeah, how do we get that data? So exactly saying, how do we get that data to them at the point of care to say, this is the most up-to-date information. This is the treatment that you should be using. Here's the references to, that. Yeah, 100% agree with that.
Yeah. And doing that in context, right? So not just giving them tools where they can look up information, but how do you create an experience and a workflow where, you're surfacing the right information to their fingertips that's contextualized to what they're saying and what they're saying with the patient.
Yeah.
I think, so much of that is part of what's hard in healthcare, right? Like it's not just about building the best model, but how do you build it into the workflow and drive actual adoption?
So you bring up a really good point, the workflow piece of it. So, I think the one thing that we have all lost sight, and I'll throw all of us in this bucket, like this is a national epidemic. We have all lost sight of the face-to-face intimate contact of a patient visit, right? Mm-hmm. The physicians have gotten to the point where everything, well, I'm exaggerating, a lot of what they do is transactional, it's administrative, it's not actually taking care of patients, right? And I think a lot of physicians, and there probably is data studies out there, I'm not familiar with them, but I think if you interviewed, I'm just giving anecdotal sort of knowledge or experience here, I think they would all sort of agree that they do a lot more on the computer and in the EMR than they really would like to. And especially going back to those, 30-year veterans and stuff compared to what they were doing, 30 years ago, it's night and day. Right.
Yeah.
And I think that's something else that is really important. And that was sort of a byproduct of these AI scribes that I didn't even mention, was that some of the feedback that we got from the physicians was they actually felt like because they weren't having to have the computer in front of them, they weren't having to take notes constantly, they weren't having to do all of these sort of transactional administrative tasks, because they had the confidence that that visit was being recorded and that there was going to be a note generated from that they actually got to return to that face-to-face intimate visit and really have a conversation with their patient that was meaningful.
Yeah.
And so I think that's sort of a byproduct or side effect of, what's coming that, again, it's hard to put an ROI on that, but I guarantee if you ask these patients, if you ask the patients, maybe looking at patient satisfaction surveys, maybe we should do some studies where, we sort of compare the baseline before AI to the, after adoption of AI scribes and see if you see any sort of increase in patient satisfaction as far as their physician visits are concerned. But I mean, I would think the patients would probably tell you that they felt like having their physician's attention and time was a much better experience for them. And I mean, the physicians are saying it, but I believe the patients would say it too.
I mean, I think what's really interesting is that, when we started the company, like that was our mission, right? And it's hard because you brought it up. It's like, how do you attribute an ROI to that? right? And but
Mm-hmm.
at the end of the day, like, everything that we're doing is in service to the patient. How do we deliver better care to the patient? How do we deliver a better experience to the patient? Um, and sometimes that ROI is intangible, but like it's the right thing to do. Right. And that's why I think I've enjoyed so much, especially working with you guys and the rest of the community oncology, space, is because, I really do think that they're prioritizing the patients and they're willing to see that as an ROI and take, that stance and say, hey, like, you know, there's other ways that we can try to extrapolate this ROI, right? Like, because,
Mm-hmm.
increasing patient satisfaction that leads to, better star ratings or HEDIS metrics or anything like that. Or, we save time and we can see more patients. But at the end of the day, right, like we're doing this in service of the patients. And that's what's so beautiful about it. And, working
Yeah.
with you guys and just the whole, community, everyone that I've met in the community oncology space, they've just been so about, servicing the patients. And I just think that's so awesome.
Yeah, and I think AI. I mean, I genuinely believe this. Again, I've been doing this for a long time, and then, I won't get into the long story of why I'm doing this, but just real quick reason why is because I fell in love with our patients. That was the reason I loved what we were trying to do. We were helping people, and I think that's why most of the people do what we do in oncology, right? Like, oncology is not one of those things you just sort of fall in. Like it's a calling, I think, for most people. And I agree with you totally. I think we are to a point in technology. Technology kind of built up those administrative tasks and those transactional kind of visits and things like that. And so I think we're finally to a point with these AI solutions that maybe we can get back to, what made everybody fall in love with what we do anyway, right? That's taking care of the patients. Let's give the clinicians the time to actually spend with the patients, make the patients feel good, have a great visit or as great as they can possibly have, and everyone feel good about it. I think AI does. I legitimately believe AI will give us the ability to do that again.
Yeah, it's ironic how the technology will make us more human, right?
Yeah, for sure.
Yeah. So Larry, I guess, really the last question I have for you. Well, Larry, I just have one last question for you. What's one more thing that you wish that more tech founders or entrepreneurs like myself, really understood about driving innovation in oncology?
Yeah. So, thinking about this from the OneOncology lens, a company like OneOncology was formed to be able to help private practices to be able to navigate a lot of things, from purchasing drug to benefits, but to making tech decisions, right? Like, what kind of tech stacks should we put in place to be able to support these clinics? And I think OneOncology does an amazing job of helping to support the practices. But I think what's really difficult is even a OneOncology, the way that OneOncology is built, the revenue is still generated from the practice. I know we talked about this. I don't mean to harp on it, but I think the one thing I realized, I recently had an opportunity to go to Washington and meet with HHS and Senator Kennedy and Dr. Oz. Now they were at a distance. I didn't get one-on-one time with them, but I did with their staff. And what I sort of realized in some of the sessions that I was in with them is that I don't think there's a great understanding of who is funding these solutions, right? And at the end of the day, we're the ones funding this, right? So you come to me with a solution, another company comes to me with a solution. We're the ones who are having to pay for it. And when you're talking about sort of private practice, OneOncology, Tennessee Oncology, again, going back to, we just don't have that expendable capital like, HCAs and things like that. And so it makes it difficult to get those things across the line. I think there was a company I dealt with a couple of years ago. I won't call them out, but they had really good pricing packages if you were a huge company like HCA, or if you were a really small company like a 5-doctor practice. But if you were anywhere here in the middle, like you got killed, right? The pricing wasn't scaled for you, and so we had that discussion with them, and so I think that's one of the things that maybe my big advice to the developers and things is that you have to come to us with something that we can afford, that, we've talked about ROI so much, but that, we can somehow, again, spend $1 to make $2, spend $1 to save $2. If you can't come to us with that, if your goal is to just get the value of your contract across the line, it's going to be a long contract process, because I'm not going to be able to push that across the line. Right. And so, and I'm not asking for the developers to take it on the chin with this. I know you guys have cost, and some of the things that are brought to us are pass through costs with, there's processing costs with AI now, as we're getting into agents and things, there's going to be telephony costs, there's going to be SMS segment cost and things like that. Right. And a lot of the vendors are going to want to pass through that cost to us. But it would be interesting if we could find creative ways to fund these things. Now, I don't know if it's pharma sponsorship. I think we're all sort of weary and burned out on, having pharma give us money, control the narrative and things like that. So I don't know that's the answer, but are there shared risk models that can be put in place? Are there partnership agreements that can be put in place where, that initial sort of platform fee and implementation fee isn't this massive, just, like heart attack, like right off the bat, right? Don't come to me with a $600,000 to $1 million, right? Like platform fee. And I'm just going to say, hey, let's probably stop talking, because there's no way I'm going to be able to meet you anywhere close to that. So that's the biggest thing for me. I think, we understand the value of what you guys are trying to build. We understand the R&D cost behind it. We have R&D cost as well, but it's just really hard for us to meet a lot. And I'm not calling you out specifically, just all of the developers. It's just really hard for us to just throw a large chunk of money at it and say, all right, I hope this works.
Yeah.
We just don't have that flexibility to do that. So that would be my main thing, because I think the developers are doing a good job of coming up with good solutions. I think the other thing that's going to be really important in the next probably 2 to 3 years is consolidation, right? And so we've got a lot of vendors coming at us. I get hit up no more than 2 or 3 times a day. Andy Kors, my CTO at OneOncology, he probably gets hit up 2 or 3 times a day. We have all these vendors that range anywhere from what we sort of lovingly call 2 guys in an LLM, all the way up to, these huge $1 billion backed companies. There's no shortage of them. And what we're trying to balance right now is, we have 50 different problems, and we have 50 different vendors who are approaching each one of those problems in a silo, right? But is there a way to, vertically integrate, I think is the big sexy term right now, right? Is there a way to like vertically integrate any of this stuff where we can get 10 problems with one vendor, right? Like, because all of these problems sort of feed into each other. RCM is a good one, right? You've got everywhere from doing benefits checks at the beginning of the patient's journey all the way to doing pre-auth, once the patient started treatment and things like that, right? And all of the things that happen with RCM in between. So is there any sort of company that has hit all of those vertical opportunities and be able to instead of having 10 solutions, 10 contracts, 10 vendors that we're having to deal with, we just have one big contract and vendor that we deal with, right? I think that's the other thing I want vendors to think about. We get a lot of startups that come to us, and I think very smart people, great ideas, a lot of people doing the same things, a lot of overlap happening right now with companies as well, where, again, going back to sort of that vertical integration, and so I think for us, that's one of the challenges that we're trying to figure out. So the more that vendors can bring us sort of those end-to-end solutions, I think there's going to be a lot more value for them, for companies like ours, or for any company, honestly.
So just to summarize, really make sure that you understand the buyer, really make sure that you have the strong case for the ROI and you're able to show and back it up. Even, go so far as to find other creative options to maybe share in the value that you create without, with trying to, unburden some of the upfront kind of investment from the customer. And also, rather than building kind of point solutions, really think about the big picture and how can you provide a full suite of solutions that solve a problem that you have from point A to point B.
Yeah.
Is that right?
Yeah, that's exactly right. Yeah.
Cool.
I think that's the things we're going to be focusing on over the next, 2 to 3 years.
Cool. Well, Larry, I really appreciate you taking the time to speak
Yeah,
with
of
me. I had
course.
so much fun in this conversation, and I thought you would be a great guest based off of all the conversations that we've had offline as well. So I hope everyone enjoyed listening, and I hope we all learned something here. And with that, thanks again.
Yeah, thank you.